All right, can everyone hear me? Okay, so I got hey, how are you guys doing? Did you survive yesterday? Got the recording going. I'm gonna do my best to keep it brief tonight because I don't know about you guys, but I'm still like recovering from yesterday. All right. Did everyone see the link to sign in? And no? Okay, hold on. Let me paste it in again. There we go. Okay, yeah, go ahead and sign in if you're just getting on. I put the slides up on my Google Drive, so you should see those. Okay, so if everyone's good, we'll go ahead and get started. So I guess I should start by saying, so that intro lecture, if you thought it was like really overwhelming, a lot of it, or I should say all of it, she's going to go over it again in the coming lectures. So like the intro is kind of like a taste of everything you're going to get, and then it's going to like come back in more detail in the lectures that are to come. So I'm going to try to keep it, like superficial tonight and, like get the highlights. And then like once you have those down, you can start building on it. So I think the pelvis, I think it's probably one of the like hardest anatomy topics to like conceptually get or like to visualize. So just give it time. It's like one of those things that it has to marinate. You can't sit down and learn all of it in one setting. You kind of have to, get it piece by piece. Okay, so let's do this. Start with the intro lecture. So the pelvis can be divided into a false pelvis and a true pelvis. So the false pelvis, this picture explains it perfectly. The false pelvis is everything that's in relation to the ilium and the lower lumbar vertebrae. And then the true pelvis is in relation to the pubis, the ischium, and the sacrum. So everything down here. And then your perineum is part of like what she called, the outside world. So everything below the true pelvis that is, starting to become outside of the body. All right, so pelvic osteology. Your pelvis is made up of 3 different bones. So you have 2 os coxa, and then your sacrum and your coccyx. This image right here is a really important place to start. Sorry about that. Get rid of this. Okay, so this image right here, make sure you know the difference between the ilium, the ischium, and the pubis. So the pubis is going to face anteriorly, and then the ischium will face posteriorly. All right. So I'm sure that, the anatomy faculty would disagree with me, but if you're trying to be the most efficient, I would not sit down and just try to like rote memorize every prominence, on those os coxa. I would try to learn it in the context of what attaches there or why is that landmark important. Because if you do that, like then you're killing, 2 birds with 1 stone and you're more likely to memorize it, okay? So let's go through a few important points. What are the attachments of the inguinal ligament? I thought I heard her mention that this was on your exam yesterday somehow. Yes, that is correct. ASIS and pubic tubercle. So make sure to like carry that with you because the inguinal ligament is still going to be a really important boundary or landmark for both pelvis and lower limb. So don't forget that. All right, what structures travel through the obturator foramen? Obturator nerve and artery. Yes. All right, what are the attachments of the sacrospinous ligament? Yeah, so the ischial spine and the sacrum, right? So right here. So important prominence, ischial spine to the sacrum. And then what are the attachments of the sacrotuberous ligament? Yeah, the sacrum and the ischial tuberosity. So ischial tuberosity right here to the sacrum. All right, so 4 kind of good important points to start with and to start getting you oriented to some of the landmarks on the os coxa. Alrighty. So again, sacrospinous ligament and sacrotuberous ligament, they're both going to be very important for the pelvis. Sorry guys, I'm back. Okay. Can you guys hear me okay? Okay. I don't know why Zoom keeps kicking me off lately, but anyways, okay, so again, sacrospinous and sacrotuberous ligament, they're going to form the boundaries for 2 very important foramina. So your greater sciatic foramen, you can see is shaded in red here. I kind of like this view. I feel like this makes more sense looking down into the pelvic bowl than looking from the side. So this area right here, this is your greater sciatic foramen. And then underneath this sacrospinous ligament, that's going to be your lesser sciatic foramen. And then eventually we'll start talking about, everything that passes through these foramina. But for now, just get this down. So we have somewhere, like a starting point. Okay, so the lesser foramen. This isn't the best pick for that, but if you can see kind of between the sacrospinous ligament and the sacrotuberous ligament, like you can see a sliver of it right in here, that would be the lesser sciatic foramen. Okay, I threw this in here. I'm not sure if they've done this to you guys yet, but make sure you can label a radiograph. So I know in Harrogate they have like large, TV screens hanging on the walls in the lab, and sometimes during practicals they'll put up an X-ray, and they'll have an arrow pointing to a certain structure. So I don't know, have they done that to you guys yet? Have you had to identify things on X-ray in the practical? Yeah. Okay. So yeah. So here's another way. For this block at least that they could do that. So make sure you can identify all of the parts of the pelvis via x-ray. Okay. This was a test question last year. So you want to know the difference between the female and the male pelvis. So the female pelvis is going to be more circular with a wider pubic angle, and the male pelvis is more heart-shaped with a smaller pubic angle. So, just that simple. That's all you need to know here. Don't worry about the specific degrees. They're not going to ask you that. You just need to know, like, in relation to the other, which one's wider, which one's more narrow, and then the shape of the pelvic inlet. Okay, so muscles of the pelvic wall. If you were confused by her arrows, I put it into words here for you. So the piriformis is going to originate from the sacrum and travel through the greater sciatic foramen to attach on the greater trochanter of the femur. And it's going to divide the greater sciatic foramen into two areas. So we have, these don't have specific names, but they're only important because of the contents that travel through. So the piriformis divides the greater sciatic foramen, and above the piriformis, you're going to have certain structures, so superior gluteal nerve and vessels passing through, and then below the piriformis, you will have certain structures passing through the greater sciatic foramen. And then you also have structures passing through the lesser sciatic foramen. So this is eventually going to be a very important picture. One thing that is going to show up, all over your exam is what structures are traveling through which foramen. So this right here is kind of a big important point to eventually get down. All right, and then we have this muscle right here, the obturator internus. So that muscle lies beneath the obturator membrane, and it travels through the lesser sciatic foramen to also attach on the greater trochanter of the femur. All right. So 2 important triangles. For now, you want to know that you have a urogenital triangle and then an anal triangle. And the division occurs right here. So I don't know, hopefully you can see that, it looks like a triangle, it looks like a triangle, all right? So start there, and she'll eventually start talking about, the muscles that make up the boundaries of these triangles, etc., the innervations and that sort of thing. All right. So this is a really awesome slide that Allie made. All right, so your pelvic diaphragm, shown in this picture over here, is made up of your levator ani muscles and then your coccygeus muscle. You want to know that the levator ani consists of the puborectalis, the pubococcygeus, and then the iliococcygeus. So even though they cannot tag this on the donor, do you guys have a model room there, or like access to models, like anatomy, yeah? Okay, so in Harrogate they have a model that shows these pelvic floor muscles. So if you can find that, I would recommend looking at it, because that's how they're going to tag. That's how they're going to tag the muscles of the pelvic diaphragm, because you're not going to be able to sort these out on the donor. So last year, basically what they did is, they tagged one of these on the model, and then, you had to know puborectalis versus pubococcygeus, and then it wasn't a big deal. All right, something clinically important about the puborectalis. So this muscle forms a sling around the anal-rectal junction, and if you have weakness in this muscle, you're going to end up with fecal incontinence. So not something that any of us probably want. And then this here, the perineal body, kind of put a pin in this for now, but just know that it's important and you want to know what muscles join together to form this structure. So it's circled in green here. And I think, as we move forward, we're going to be coming back to a lot of this stuff. Okay, same thing with the UG diaphragm. You're going to get this again when you have the male and female specific lectures. But for right now, I would just start learning, first of all, just start with the layers, from deep to superficial, or kind of like from inside the body to outside. So you're going to have the superior fascia of the UG diaphragm, and then you have the inferior fascia of the UG diaphragm, and then a superficial perineal fascia. So perineal, that's part of the perineum, so that's going to tell you that it is towards the outside. And then another important point is to know the contents of each of these spaces. So you wanted to know, a question they like to ask is about these glands. So in the male, in the deep perineal space, you have the bulbourethral glands or Cowper's glands, and then in the superficial space, you have the greater vestibular glands. Okay, so for now, memorize the layers and know the contents. And then I think being able to conceptually understand this, it's something that's just going to come with time. At least for me, it did. I didn't really get this right away. It took a couple weeks. All right, so we'll come back to all this for sure. All right. So over here we have the male, and then here's female. So a few important spaces to know. First, you have the retropubic space. So behind the pubic bone, this space right here is a retropubic. And then you also have a retrorectal space. So behind the rectum is the retrorectal space. And then in the male, you have a pelvirectal, or also known as rectovesical space. So what does this word right here mean? Vesical? Right, bladder. So if you just think about what this word is telling you, rectovesical, so between the rectum and the bladder. And then in the female, so of this entire slide, the space that they're most likely to ask about, and probably will ask about, is this rectouterine space. So between the rectum and the uterus. And why is this space clinically significant? Did she talk about that? Okay, yeah, so this is just basically another space where fluid can accumulate. All right. And then, so in the male, so in red, I've outlined really the only thing you need to know on this slide. So in the male, keep in mind that urine can leak into the retropubic space. So this space behind the pubic bone, if there is a posterior urethral injury. So eventually you're going to learn the parts of the urethra in the male. So back here, it's the membranous urethra. So you can have urine leaking into the retropubic space. And then also on this side, you can have urine escaping into the perineal space, and then also blood accumulating in the scrotum if you have, perforation of the spongy urethra, so the part of the urethra within the penis, or if you have a tear in this Buck's fascia. I know, haven't got to some of these names yet, so, another thing, keep in mind this is just the intro lecture, so another thing to kind of keep a pen in and, come back to when you've had the male anatomy. All right, so pelvic neurovasculature. I actually have some extremely helpful things to share for this. At least I think they're helpful. Okay, so this first trick right here, this is going to get you all of the sacral plexus, all right? So if you go to this video, he'll explain how this works, but I'll try to just walk you through it, okay? So your sacral plexus is formed by ventral rami of L4 to S4. So when you draw this out, you're going to start by going 4, 5, 1, 5, 1, 2, 1, 2, 3, 2, 3, 4, okay? And you're going to draw out your numbers. And then you're going to draw on these lines. So you're going to box it off. All right? And then for the names of the nerves, the mnemonic is SIPS. So you'll start up here. So L4 to S1, so 4, 5, 1 are the nerve roots for the superior gluteal nerve, the nerve to the quadratus femoris, and then also it supplies the innervation for the inferior gemellus, which we'll get to. Okay, and then L5 to S2, so 5, 1, 2 is inferior gluteal nerve to the obturator internus, and then innervation for the superior gemellus muscle. S1 to S3, so 1, 2, 3, and there's your P, is the posterior femoral cutaneous nerve. So here they're just calling it posterior cutaneous nerve of the thigh. That's fine, but they're going to want you to know this name. And then pudendal nerve, S2, 3, and 4. And then your sciatic nerve. So what you do for sciatic is you draw a line down under sciatic. So that tells you sciatic is L4 to S3. All right, does that make sense to everyone? If it doesn't, watch the video and you can watch him draw it out. But I think this is like gold. This is so helpful. You're going to have to know all of this. So everything on this slide is extremely important. So what does S2, 3, and 4 do? Keeps the what off the floor? Yeah, exactly. So important point there. And then also your sciatic nerve is going to emerge beneath what muscle? Piriformis, correct. So big landmark there for finding the sciatic nerve. You find the piriformis and emerging, if you're looking at the gluteal region from the back, emerging beneath it is going to be the sciatic nerve. And you'll definitely see what I mean when you start dissecting that area. Okay. Yeah, so even if you are like one of those people that hates mnemonics, like I would really consider this one. It's so helpful, and you'll remember it too, like because you'll remember how to draw this out, so it'll stick with you, which is important because you do have a cumulative final. All right. So, autonomics of the pelvis. Um, so, like, just a tidbit of advice. If you don't understand something when they explain it in lecture, like, instead of just trying to keep rewatching it and trying to get it, like, try an outside resource because there might be somebody out there who explains it a little bit better or clearer. Like on Dr. Dudsick's slide, she had like a giant typo, which I think could have been confusing to everybody. So she put here inferior epigastric plexus instead of hypogastric. So just make sure that you realize that and you caught that, um, and change that in your slides. So inferior hypogastric plexus. All right, so I'm going to try to walk you through this, but I definitely recommend watching this guy's video. He also has a video for like the splanchnic nerves of the abdomen. So if you didn't quite get that this last exam, I definitely recommend going to that video before the cumulative. Okay, so we'll start down here. So your organs inside the pelvis or the viscera, they have mixed autonomic fibers that make up these plexuses that are, specific to the organ or the tissue. Okay, and these mixed fibers are coming from the inferior hypogastric plexus. Okay, so where are the fibers that make up the inferior hypogastric plexus coming from? So part of them are coming from your pelvic splanchnic nerves. So that's from spinal levels S2 to S4. And that's on either side. So parasympathetics contributing to the inferior hypogastric plexus. And then part of those fibers are coming from your right and left hypogastric nerves. And these are sympathetic fibers that are branching from the superior hypogastric plexus. Okay? So you have sympathetic fibers coming from the superior hypogastric plexus, which is splitting into a right and left hypogastric nerves. And these right and left hypogastric nerves carrying sympathetic fibers, along with your pelvic splanchnics from S2 to S4 carrying parasympathetic fibers, they're going to join together in this inferior hypogastric plexus. And keep in mind, this is bilateral, so on either side. And then, so now we have mixed fibers from the inferior hypogastric plexus that are running to each of these structures in the pelvis. Does that make sense? Sort of. If not, watch the video. Yeah. So everything that you need to know about autonomics. Parasympathetics contribute to the mixed fibers. So mixed means that you have both sympathetic and parasympathetic innervation going to these structures. Okay, and so when I say point and shoot, what am I referring to? So what is the point referring to? Do you guys remember? Did she talk about this today? Point and shoot. Does that sound familiar? Right. An erection. Okay, so when you have an erection, is it a result of vasoconstriction or vasodilation? Correct, vasodilation. And is that a result of parasympathetic or sympathetic fibers? Parasympathetic, right? And then what is the shoot referring to? Ejaculation, okay. And is that a result of parasympathetic or sympathetic fibers? Right, constriction and sympathetic fibers, yeah. So make sure you associate sympathetic fibers, vasoconstriction, and then ejaculation, and the point part, an erection, and vasodilation. All right, so this is going to get you, all of those points there. So remember, point and shoot. All right. Next, we have the branches of the internal iliac artery. So when she said that you need to learn these based on where they're going, that's definitely the truth. Like, I know that there are mnemonics out there, but I'm not even going to say them because I don't think it's helpful. There's so much variation in the pelvis as far as like where the vasculature branches from. You need to identify it based on, what it is supplying and not a certain order. So if you just learn an order, that's not going to help you with this. Okay, so internal iliac arteries. So we're right here. So your common iliac on either side is going to split into an external and internal iliac. And then you're going to have a posterior trunk and an anterior trunk. So we're just going to look at the posterior trunk right now. You have 3 branches, important branches. So first is the iliolumbar, and then the lateral sacral arteries, and then your superior gluteal artery. Okay, so just posterior trunk's not bad. 3 important branches. The one that they would be most likely to tag would be this superior gluteal artery, and that's because it's passing through 2 structures right here. So you have landmarks in order to identify this artery. So what is this artery passing between? What is this and what is this? So let me rephrase that. What 2 nerves? Right. Lumbosacral trunk and S1. Yeah. So those are going to be your landmarks in order to identify superior gluteal artery. And they definitely tagged that one last year. And I still think that would be like the most likely one that they would tag. But if you see something running back up towards the lumbar spine, that's going to be iliolumbar, no doubt. All right. So the anterior trunk of the internal iliac. So let's start with the umbilical artery. Your umbilical artery becomes, what was this structure here? Right, medial umbilical ligament. And then off of the umbilical artery, we usually have the superior vesical artery. So this is a usually kind of thing. This relationship definitely isn't a guarantee. So you want to look for where it's going. So superior vesical, where is that going to be headed? What is that supplying? The bladder, right? So the superior portion of the bladder. And then your obturator artery, that's passing through what? Which canal? Yeah. So passing through your obturator foramen. And, okay, so that's 3. And we're naming these based on where they're going in your landmarks. So obturator artery, passing through that foramen. Superior vesicle, supplying the bladder. Okay. Umbilical was off median sacral. If I did, I didn't mean to. No. So umbilical artery is a branch of the anterior trunk of the internal iliac. Maybe it was that the umbilical artery is going to become the medial umbilical ligament. Maybe that's what you heard. Yeah, so umbilical off of the anterior trunk of the internal iliac becomes the medial umbilical ligament. All right. So this is showing, the male vasculature. So in the male, we have an inferior vesical artery. So down here, going to the inferior portion of the bladder. And then you're typically coming off of the inferior vesicle, which I imagine that might be what they're trying to show here. Don't quote me on that. But you also have an artery going to the ductus deferens, okay? So that's why inferior vesicle is typically considered a male artery. And then you also have an inferior gluteal, a middle rectal, an internal pudendal, and then in the female, so not shown here because we're looking at the male vasculature. The female is also going to have a uterine artery, which typically the vaginal artery will branch from. So I want to say she said in class that inferior vesical and vaginal were considered equivalent structures, like between male and female. So that's why males have inferior vesicle, and then female, the equivalent structure is the vaginal artery. All right, so inferior gluteal nerve, you're going to identify because it's going to be passing through what 2 structures or what 2 nerves? So this right here. Yeah, S2 and S3. So yeah, these are definitely 2 that they could easily tag because you have really nice landmarks to identify them. And they're going to tag a body with that relationship because that's what they taught in class. So most of what they tag, it's going to have the normal or the expected branching, just in case, you're worried about that. Yeah, so remember superior gluteal, it's going to pass between the lumbar plexus and S1, and then inferior gluteal between S2 and S3. So a really good way to help identify those. So middle rectal is off of the anterior trunk of the internal iliac. Where is superior rectal coming from? Think back to yesterday. So middle rectal artery, where did superior rectal artery come from? What was it a branch of? Right, correct. IMA. Okay, so superior, middle. So your inferior rectal, to complete the picture, is going to branch from the internal pudendal artery. Okay, so now you know where superior, middle, and inferior rectal are coming from. And then here that is again. So bringing this slide back, make sure you remember this. All right. I can pretty much guarantee that they're going to tag this relationship because they make a huge deal about it. Okay, so this water under the bridge Is anyone familiar with what I'm talking about here? Like, what is the relationship that I'm talking about? Yeah, the ureter under what? Under what artery? What is this artery? Somebody be brave. Correct, the uterine artery. So water under the bridge, the water is referring to the ureter, because, water, like you have urine passing through the ureter. So that's the water. The bridge is the uterine artery. So why is this relationship clinically significant? Why is this important? If you were a surgeon, why would you care about this? You don't want to snip it when you're doing what? What would you be doing that you might accidentally snip it? So what is the structure right here? Yeah, so when a surgeon is performing a hysterectomy, this is a relationship they have to watch out for, because if when you're ligating this artery, if you nick somebody's ureter or cut it or completely sever it, and as you can imagine, this is going to lead to all sorts of kidney related complications. So yeah, I'm pretty sure they like to tag this every year, so be aware of this relationship. And make sure, what was the, yeah, they're both going to the bladder, so the superior vesicle, superior part of the bladder, inferior vesicle, inferior part of the bladder. Typically, they associate the inferior vesical artery with the male because, let me just go back. They associate it with the male because a lot of times there's a branch coming off of it supplying the ductus deferens. So, like she mentioned in class, that it doesn't necessarily mean that a female won't have an inferior vesical artery. It's that we usually, talk about it in the male. So, kind of like one of those iffy areas of anatomy. But as far as the practical last year, like I don't recall them tagging a vesical artery. If they did, it was probably superior. But yeah, anyways. Yeah, so make sure you know this one is associated with the male. And then, of course, it's always going to be only the female that has a uterine and a vaginal artery. So this is always only associated with the female. Alrighty, so water under the bridge, super important. I thought this drawing was pretty cool. So it's showing you, the foramina that these arteries are passing through. Yeah, so fun drawing. And then she also had several slides about lymph. Have they asked you guys about lymph yet on your written exams? Have you had any questions about lymph drainage on the written exam? Yes, no? Don't remember? You don't know if you have yet? Okay. I know they did a couple times last year, so this might, maybe, okay. They did a few times last year, so this would be one place where it's important and it would be easy to ask because you have, so the lymph is draining to different areas from all of these structures, if that makes sense. So the one that she pointed out was the fact that the ovaries and testes, they don't follow the venous drainage. They skip all the way up to the para-aortic lymph nodes. So, And they might have asked this last year. Like, that just seems really familiar. But we were. Right, and this is out of first aid, so it's like, regardless of whether they ask on the exam, like it's something like obviously that for boards you need to know. But if you're like triaging, if you get to that point, if you're just gonna know one of these, I would know the one about the ovaries and the testes, skipping the para-aortic lymph nodes. Yeah, yeah, that's the one that she like took a lot of extra time to point out. So this first one is probably like quote unquote highest yield. But, if you have time, you know, try to learn all of these, because you have to know it for boards. Okay. All right. Well, short and sweet since we only have 2 lectures. Any questions, concerns? Yeah, you're welcome. Oh, yeah, gonadal. Okay, so ovaries and testes, your gonadal lymph drainage, it's unique because it's not following the venous drainage. It's skipping all the way up to the para-aortic lymph nodes. So I know she had, yeah, they drain directly into para-aortic lymph nodes. I know she had several slides designated to lymph drainage. So hopefully she has a good picture showing you para-aortic lymph nodes. But just make sure you take a look at that. Yeah, that's correct. BP, that's correct. Yeah, no problem. Hold on just a second. Um, Let me get out of this. Okay, there's the drive. Tell where each artery. Okay, let me go back. Yeah, and when you have lab, it's gonna come together a lot easier. Okay, let me just run through them real quick again though. Okay, so for the posterior trunk, the iliolumbar artery, that's running, it's like going up. So back up towards the lumbar spine. The lateral sacral arteries are branching out laterally towards the sacrum. So the names are really telling you where they go, a lot of them. So iliolumbar, lateral sacral, and then superior gluteal. So it's passing between the lumbar, um, through the lumbosacral trunk here, and then S1. So that's an important landmark. And then, all right, so off of the anterior trunk, we have umbilical. So that's becoming medial umbilical ligament. And then obturator. So obturators passing through the obturator foramen. The superior vesical artery that's supplying the bladder. So keep in mind, like you can't, I mean, obviously they're not showing the bladder here, but in theory, if there was a bladder, it would be running to the superior portion of it. And then the inferior vesicle, so it's coming down beneath the bladder to supply the inferior portion. And this is typically associated with the male because a lot of times it gives off a branch to the ductus deferens. So I believe it's just called like artery to the ductus deferens. And okay, so we also have an inferior gluteal passing between S1, or I'm sorry, S2 and S3. and then a middle rectal, an internal pudendal, giving rise to an inferior rectal. And then in the female, you're going to have a uterine artery, which usually gives off a vaginal artery. And so all of these are branches off the anterior trunk of the internal iliac. Is that good? Middle rectal. No, it looks like it's coming off before it passes between S2 and S3. But like keep in mind, other than like superior and inferior gluteal and maybe the obturator artery, a lot of this branching isn't like a definite thing. Like you're going to see a ton of variation in the pelvis as far as the arteries go. So you just have to look at where they're going. Like if they're supposed to be supplying the rectum, if you see an artery headed towards the rectum, it has to be one of the rectal arteries. Yeah, exactly. Look for the target. Yeah, that's the best way to say it. And then from there, you can think about, try to trace it back to see if you can find its origin and name it. But I promise, in the practical, they're going to be fair. They're going to show you the relationship and all that. So don't stress about it. All right. Any other questions? Yeah, you're welcome. You're welcome. All right. If you guys don't have any other questions, I'm going to head out of here, and hopefully the recording worked if anybody asks you. So, and I'll get that posted within the next day. You guys have a good night.